Okay. Work exacerbated asthma. So again, the definition for this is it's a patient, he has asthma, and then there is nothing. For example, he had asthma during the childhood, and then after nothing, and he began to work, and then he developed asthma again. This is typical work exacerbated asthma. And for example, when the symptoms with this patient, this is about pathophysiology, about work exacerbated asthma. This patient, it is not about the diagnosis. This patient, there is no increase of eosinophils. This is the difference with occupational asthma. If you look, the definition of a work exacerbated asthma is a patient who have asthma at work. You perform a specific inhalation challenge, and the specific inhalation challenge is negative. And if you look at the eosinophils that it produces, those who have a positive specific inhalation challenge, there's a difference between the level of eosinophil at work and off work, as I showed you before. But with a negative specific inhalation challenge, there's no difference. So first, in terms of pathophysiology, is the difference. There's no eosinophils. So the induced sputum, the diagnosis will, for example, in the work exacerbated asthma, also you could have, there are some publications who demonstrate that an increase of neutrophils at work as compared as the different with occupational asthma. But as I told you, now it's very difficult to try to find the pathophysiology. It's exactly what the question, there was a question about that, about the difference in pathophysiology between occupational asthma versus work exacerbated asthma. And in fact, it's not so easy, because here, of course, you have an increase of a neutrophil, but I showed you that in occupational asthma with wheat, for example, you could have also an increase of neutrophil. So things are not so easy to demonstrate. So that's my conclusion. So it's very, very short, sorry. It's shorter than I thought. For clear IgA-mediated occupational asthma, it seems that the major pathway is Th2 However, all occupational asthma known to be IgA-mediated are not IgA-mediated. That means that, as I told you, which is called allergic asthma, like a wheat flour, you could have a Th2 mechanism or eosinophilic inflammation, but you could have also an increase of neutrophils. For immunological asthma, not IgE-mediated, the mechanism is mostly T2 when the diagnosis is based on specific inhalation challenge. I showed you that when the patient, they have occupational asthma, when they are exposed to during the specific inhalation challenge, there is an increase of eosinophils. For irritant asthma, the epithelium damage seems the primum movens, that means the primary cause. And after the genetic, the antioxidative. So for irritant, there are a lot of mechanisms we could be induced. It's exactly, we were talking during the break about the flowers, because I think it seems that it is a very important issue in Colombia. All the workers working with flowers. Of course, they are exposed to flowers, and maybe there is, I don't know, but there is maybe an allergic pathway, something allergic, they have specific IgE against an allergen, but also they are exposed to to a lot of chemicals. And there are also the factors. I understood that there was a like fridge, and in this fridge, they are exposed to cold air, but they are also exposed to high levels of chemicals. And also they have mite. So you need to understand that always it's a mixture. It's exactly the question last time. So high molecular weight agent versus low molecular weight, that means there are a clinical pattern, of course. I told you high molecular weight, more rhinitis, more atopy, but it is not always true. T2 inflammation is strongly impacted by the exposure. It's exactly, in allergy is the same. You have people who are allergic to birch pollen, some of them, they develop an increase of activated eosinophils. And these patients are those who are the more severe, the more T2, the high T2 responders. It's exactly the same for occupational asthma. Yes, the same agent I told you, the same agent can be the origin of several profiles, and prognostic factor of inflammatory patterns can be evaluated. About severity, well, this is important because it's very practical. 16% of the patients have a severe occupational asthma. In the general asthmatic population is 4 to 6. So there are more severe asthmatic patients in occupational asthma. The frequency of severe asthma decreased significantly when the patients are no longer exposed. You show they have the patient who are when they were exposed during sick, and when they are not exposed, there is a decrease. So it's clearly that when you have a severe occupational asthma, you need to remove it as soon as possible. The determining factors for the existence of severe occupational asthma when patients are exposed to their work environment include not only potentially modifiable occupational factors like level of exposure, duration of symptoms, but also socio-demographic factors and clinical factors, low level of education, asthma in the childhood, chronic sputum. And I can understand that the people who are working with flowers in your country, they are pretty from low level of education. They are pretty poor population. And of course, this is the occupational asthma. It's the same for cleaning. In Europe, the people who are the cleaners are those who are the less rich. They are the poorer people. And this is also an issue, for a social issue, because after, if you say, okay, you must stop your job, and what are they going to do? And this is also a problem. After cessation of exposure to the sensitized agent, the severity of asthma seems to be mainly determined by individual socio-demographic and clinical factor. When the patient is not exposed, it's exactly like the other asthma, low level of education, obesity, chronic sputum. The study identified the risk factor for severe occupational asthma and should make possible to better target subjects at risk. We need to benefit quickly from eviction, I told you that, but require confirmation. This, what we found, of course, we need to, we are going to perform a follow-up study for all this occupational asthma to see what is the difference between the positive specific inhalation, those who had a positive specific inhalation challenge versus those who have a negative specific inhalation challenge. Okay, I wanted to thank all the people in my group, and particularly Nicolas Migueres, who helped me, and those, and you can see that there are people you know, that Santiago Quirce, Joaquim Sastre, Javier Munoz, and all the people who are involved in the cohort.